Good afternoon to all of you. Very good afternoon. So I'm Dr. Pramod Kumar from the Department of Geriatric Medicine, and we'll be presenting an interesting case that we came across in our department here as CCR. So it's a very common diagnosis that we see in our OPD or our inpatient very commonly, but it was a rare manifestation of the disease or a unique association that we are presenting here that we thought was important to be discussed on this forum. So we are presenting this case as our CCR, and with that I would like to invite our residents. Dr. Shreya will be presenting the case and Dr. Sunil would be presenting the review of literature. So Dr. Shreya, you may start the case.
Thank you, sir. Without further ado, I'd like to start with the patient profile. She's a 70-year-old female patient. She's a resident of Delhi. She's a homemaker, and she's a known case of cervical and lumbar spondylosis. She presented with the chief complaints of generalized weakness for the last 6 months, loss of appetite and weight for the last 6 months, fever with chills for the last 2 months, jaundice for the last 2 months, and abdominal pain for the last 1 month. She was in a usual state of health 6 months back, following which she developed generalized weakness, which was insidious in onset and gradually progressed over the last 6 months, associated with fatigue while walking and performing her household chores. She also had a history of loss of appetite and weight, which was unintentional weight loss noticed on loosening of clothes, and as loss of appetite from 3 chapatis per meal to 1 chapati per meal over the last 6 months. She also had fever with chills for the last 2 months, which was intermittent, low grade and not documented, and relieved with medication. She also had jaundice for the last 2 months and abdominal pain, which was insidious in onset and gradually progressive over the lower left side of her abdomen for the last 1 month. Moving to the negative history, she had no history suggestive of vasculitis, no history suggestive of CLD, no altered bowel habits, and no history suggestive of redness, swelling, or pain over her. Past history, she doesn't have any known comorbidities like diabetes, hypertension, coronary artery disease, CVA, or tuberculosis. She was recently diagnosed with cervical and lumbar spondylosis. She has history of admission during March and April 2022 in Safdarjung, wherein she has received 2 units of blood transfusion in each admission. No further documents regarding these admissions were available. Coming to her personal history, she is non-alcoholic, non-smoker, consumes a mixed diet, has reduced sleep because of her pain, and no bowel or bladder abnormalities. In the geriatric history, she has no history suggestive of fall, cognitive impairment, delirium, urinary incontinence, hearing or visual impairment, and is maintaining her ADLs. Summarizing my history, she is a 70-year-old female patient, a known case of cervical and lumbar spondylosis, who presented with complaints of generalized weakness, loss of appetite and weight over the last 6 months. She also had history of fever with chills for the last 2 months, jaundice for the last 2 months, and abdominal pain for the last 1 month. Based on my history, for a differential of anemia with jaundice, abdominal pain and fatigue, I'd first like to rule out infective etiologies like viral hepatitis, tuberculosis, malaria, kala azar, cholangitis, and other viral infections. My second differential would be autoimmune disorders like autoimmune hepatitis, SLE, primary biliary cirrhosis, hemolytic anemias, and sarcoidosis. I'd also like to rule out malignancies like hepatocellular carcinoma and hematological malignancies, and other causes like CLD and gallstone disease. Moving to the examination, her vitals were stable. She had a BMI of 21 kg per meter square. On general examination, she had pallor and icterus. She did not have clubbing, cyanosis, lymphadenopathy, pedal edema. She also had suprasternal pulsations. On systemic examination of the abdomen, she had on inspection fullness on the left side of the abdomen. On palpation, the spleen was palpable in the left hypochondrium, directed towards the right iliac fossa and 8 cm from the left subcostal margin. She also had a liver which was just palpable below the right subcostal margin. On percussion, her liver span was 11 cm and spleen size was 17 cm. There was no free fluid in the abdomen and bowel sounds were heard. Other systemic examination was normal. In her comprehensive geriatric assessment, her Charlson's comorbidity index was 3 points. Her BADL and IADLs were maintained. MNASF was 9 on 14, which means she had risk of malnutrition. Her Morse fall risk score was low. Her frail scale, she had frailty with a score of 3. There was no premorbid mood disorder, no cognitive impairment, and her Sarkov score was 5 with no neglect. Based on history and examination, I'd like to remove the following diagnosis from my previous differentials. 1, viral hepatitis, 2nd, cholangitis, and 3rd, gallbladder malignancy, and 4th, gallstone disease. The remaining are likely to occur with anemia, jaundice, and splenomegaly. Her baseline investigation on the first admission was a hemoglobin of 6.2 gram per deciliter, a total leukocyte count of 2,866, an absolute neutrophil count of 1,347, platelet count of 93,000, and total bilirubin of 2.8. Her viral, malaria, and RK39 antigens were negative. Her viral marker was negative, dengue negative, and blood cultures were sterile. On presentation, she had urinary tract infection, which subsequently improved. Her sputum AFB on admission was negative. Based on this initial assessment, we drew that the patient had pancytopenia with indirect hyperbilirubinemia and splenomegaly. Based on this, I kept the following differentials. I further subdivided malignancies into hypocellular marrow and hematological malignancies with a cellular marrow, apart from the solid organ malignancies. So in a hypocellular marrow, our main differentials were a hypocellular MDS with an ALL and lymphoma. Amongst the causes with cellular marrow, primary to the bone marrow, we had hematological malignancies like lymphoma, myelodysplastic syndrome, PNH, myelofibrosis, and HLH. Amongst the other secondary causes, we had infective etiologies like tuberculosis, malaria, Kala-Azar, and viral infections like Epstein-Barr and cytomegalo. Amongst the autoimmune causes, autoimmune hepatitis, SLE, and sarcoidosis and hemolytic anemia. Metabolic like B12 and folate deficiency, and other causes of hypersplenism like CLD. Of these, the causes which were found associated with massive splenomegaly, like in our patient, were sarcoidosis, lymphoma, chronic lymphoid leukemia, chronic myeloid leukemia, hairy cell leukemia, myelofibrosis, and autoimmune hemolytic anemia. Based on the above information, our investigations were steered towards identifying the cause of pancytopenia and splenomegaly. We evaluated anemia using an iron profile and a peripheral smear. We also decided to perform imaging investigations to rule out mediastinal and abdominal lymphadenopathy. Further evaluation, we found that her ferritin was raised, it was 704. She had an elevated retic count of 8.6, low vitamin D, inflammatory markers like ESR and CRP were raised, her LDH was raised, and her autoimmune profile was negative. On peripheral smear, she was found to have anisopoikilocytosis with polychromatic neutrophils and spirocytes, and we were advised to perform a direct Coombs test. On the direct Coombs test, we found that she had pan-reactive antibodies which were of the warm type and had a high titer of 4, which was suggestive of warm antibody autoimmune hemolytic anemia. Further, on the ultrasound abdomen, we found that she had small periportal and para-aortic lymph nodes with 18 centimeters spleen. For further radiological images, I'd like to call.
CCT chest and abdomen was done for this patient on 18/5/2022. These are all lung window axial section of the patients. There are few linear fibrotic bands noted in the right middle lobe and lingula. And rest of the lung parenchyma is normal, no evidence of consolidation or central lobular nodules noted. And the axial section abdomen shows there is moderately enlarged spleen, and the spleen is pushing the left kidney medially and inferiorly. And there is evidence of few enlarged lymph nodes at the left para-aortic location, measuring SAD of 13 mm noted in the left para-aortic location. No evidence of calcification or internal necrosis noted within it. It's a coronal reformatted image showing the enlarged spleen and enlarged left para-aortic lymph node. So radiologically, there are fibrotic changes in right upper lobe, middle lobe, and lingula, suggestive of post-infective sequelae. No evidence of active infection noted in the lung parenchyma, and splenomegaly, retroperitoneal lymphadenopathy.
I'd like to invite Dr. Jasim to describe the PET films.
This is the MIP image of the FTG PET scan, which was done on 23rd of May. And in this MIP image, we can see that there is abnormally increased uptake in the mediastinum and abdomen, along with a massive splenomegaly with few foci of uptake in the spleen. And these are the coronal images showing the mediastinal lymphadenopathy, and there is increased uptake in the mediastinal lymph nodes, and that can be seen in the axial images also. And this is the coronal images of the abdomen, and we can see that there is a massive splenomegaly along with some foci of increased activity in the spleen, and there are some FTG-avid retroperitoneal lymph nodes. So our impression was there are metabolically active mediastinal and abdominal lymph nodes with splenomegaly and splenic involvement, and our differential diagnoses were lymphoma, disseminated tuberculosis, and lymphoproliferative disorder.
Thank you, sir. So based on these investigations, we had established that the patient was having warm antibody autoimmune hemolytic anemia. She also had splenomegaly with lymph nodes visible in the axilla, mediastinum, and abdomen. The cause for hemolytic anemia and splenomegaly was yet to be ascertained. So we decided to go ahead with an ultrasound-guided axillary lymph node aspirator biopsy and a bone marrow biopsy. On the axillary lymph node FNAC, we found that she was having only reactive lymphoid tissue. On the bone marrow biopsy, she was found to have adequate cellularity with no evidence of fibrosis nor any atypical cells. Based on these, we were able to rule out some of the previously established differentials. First, based on the imaging absence of features suggestive of CLD, I was able to rule out CLD. Second, there was no evidence of any solid organ malignancy. Third, cellularity was retained, so no hypocellular marrow. And third, of the hematological malignancies, apart from lymphoma, others were isolated. Also, based on our previous investigations, we were able to rule out malaria, Kala-Azar, B12 and folate deficiency, and autoimmune features. Based on these, we were able to narrow down our differentials to tuberculosis, sarcoidosis, viral infections, hypersplenism, and lymphoproliferative disorders. Assuming that she was going to have, assuming a high risk of tuberculosis in our country, we performed a bronchoalveolar lavage, on which we could find on liquid culture that she was having evidence of tuberculosis which was sensitive to rifampicin. On the transbronchial lung biopsy, there was evidence of patchy chronic inflammation. A diagnosis of autoimmune hemolytic anemia secondary to disseminated tuberculosis was made. Patient was started on ATT along with steroid therapy since a definitive evidence of infection was established. Patient was started on prednisolone at 45 milligrams once a day, which was tapered over 4 weeks. Patient had improved symptomatically and was discharged. These are the blood parameters. At the end of 2 weeks of ATT, we find that her hemoglobin had improved to 11.9, total leukocyte count had improved to 8,300, and her bilirubin had reduced as well. And platelet count had also improved. Patient, however, had discontinued treatment in between the course and was a loss to follow-up. She once again presented to us with generalized weakness, loss of appetite, and weight for the last 4 months after discontinuing ATT. Patient was admitted and re-evaluated. These were her baseline investigations on the second admission. She had a hemoglobin of 7.4, a total leukocyte count of 1,597, absolute neutrophil count of 590, platelet of 76,000, and total bilirubin of 1.7. She also had a raised LDH and a low vitamin D. The peripheral smear on second admission showed pancytopenia with non-severe neutropenia, and the direct Coombs test was 4+ positive. I'd like to call Dr. Sullivan.
So a second PET-CT was repeated on June 27, and from the MIP image we can see that there is overall reduced uptake in the lymph node mediastinal and retrofrontal lymph nodes, and there is absence of the focal activity that was seen in the spleen initially. So these are the coronal images which is showing reduced FDG uptake in the mediastinal lymph nodes, and these are the axial images showing the same. And coming to the abdomen, and we can see that the previously noted focal FDG uptake in the spleen was not seen. However, splenomegaly was persisting. And we can also see that the FDG uptake in the previously noted retrofrontal lymph nodes has reduced, and there was resolution of previously seen some of the lymph nodes. So our impression was there are metabolically active mediastinal and abdominal lymph nodes with splenomegaly. As compared to previous scans, there is resolution of splenic lesions with reduction in metabolically activity of mediastinal and abdominal lymph nodes.
Thank you, sir. We once again performed a bone marrow biopsy on the patient, which showed cellularity of the marrow was intact. She had no atypical cells in the marrow, and there was megaloblastic erythroid hyperplasia. After discussion with intervention radiology, we found that the periportal and peripancreatic lymph nodes were not amenable to CT-guided biopsy. Since the patient was previously diagnosed with tuberculosis and had incomplete treatment, in consensus with pulmonary medicine, hematology, and ID team, we started the patient on ATT. A diagnosis of autoimmune hemolytic anemia secondary to disseminated tuberculosis was made. Patient was started on weight-based ATT with Benadone and tapering doses of steroid, prednisolone 25 mg BD, which was tapered over a 2-month period. The patient improved symptomatically on therapy and her blood parameters improved as well. These images, they can show the difference of the hemoglobin count after treatment. From 7.4, it had improved to 11. The TLC had improved from 1,597 to 5,210, and her platelet count had also improved from 76,000 to 82,000. The total bilirubin, direct bilirubin, had also normalized.
A third PET CT was done on 9th of this month, and we can see that as compared to previous two scans, there was further reduction in the FDG uptake in mediastinal and abdominal lymph nodes and reduction in splenomegaly. So these are the coronal images. We can see that there is a reduction in splenomegaly as compared to the previous scan, and there is also a reduction in the FDG uptake. And these are the actual images that is showing there is a reduction in the metabolic activity of the paralytic lymph nodes and resolution of rest of the retroperitoneal lymph nodes in this. So, and also in mediastinal, we can see that there is calcification of the lymph node as well with reduction in the FDG uptake. So, induction was metabolically active mediastinal and abdominal paralytic lymph nodes with splenomegaly, and as compared to the previous scan, there is resolution of majority of abdominal lymph nodes with reduction in size of spleen, which suggested as partial response to therapy.
Thank you, sir. So based on this, we made a final diagnosis of disseminated tuberculosis inducing warm antibody autoimmune hemolytic anemia. The patient was also having frailty. She was at risk of malnutrition, at risk of sarcopenia, and had cervical and lumbar spondylosis. I'd now like to invite Dr. Sunil to present with the RO.
Thank you, Dr. Shreya. Good afternoon, everyone. My name is Dr. Sunil. I would like, now we will discuss about TB-induced autoimmune hemolytic anemia. So, anemia is very common in TB, and it has a prevalence of 61%, and around 11% patients present with a severe anemia. Anemia in TB can be due to multiple mechanisms. One of the mechanisms is increased inflammatory state that leads to increase in IL-6 and TNF-alpha that causes increase in hepcidin, which down-regulate the absorption from GIT and intracellular sequestration. It also leads to a decreased erythropoiesis from bone marrow and also decreases the lifespan of RBC. And in TB, there is also malnutrition happen that leads to vitamin B12 and folate deficiency. Simultaneously, chronic inflammatory state also created, and it leads to secondary infections also that creates a hypopherenemia state and leads to anemia of infection and iron deficiency anemia. So AHA is a rare presentation of TB, but it can present in up to 5 to 10 cases per million per year, and it is a decompensated acquired hemolysis due to immune person's basically host immune system that act its own RBC and leads to hemolysis. In older adults, chronic and relapsing cases are more common that we have seen in our patient, and it has a higher mortality rate, around 4%, which is due to increased risk of infection, event syndrome, acute renal failure, and increased thrombotic risk. Autoimmunity in AHI is mainly multifactorial. It can be due to environmental factor, genetic factor, and it can also be due to breakdown of both central and peripheral tolerance. It can be explained with the simple example like infection like parvo B virus or mycoplasma leads to modification in RBC antigen, and which activates polyclonal B cells and formation of antibody, mainly IgG and sometimes IgM also, that leads to complement system activation and changes in cellular immunity through immunoregulatory cytokine and leads to RBC destruction, which happens by mainly two mechanisms. First is warm antibody mediated, which is through IgG antibody that opsonize on RBC surface and move to spleen, where it is phagocytosed by macrophages and antigen presenting cell. Some of the cell escape the mechanism and present in the peripheral blood as a microspirocyte, and some of the cell and the second mechanism is cold antibody mediated, where heavy chain IgM bound to the RBC surface with the help of C3b it forms agglutination and can move to liver, and there it phagocytized. Sometimes it doesn't go to the peripheral organ like spleen and liver, and hemolysis occur in the blood only due to activation of complementary pathway and a membrane attack complex formation. So AHI is classified basically on the basis of underlying immunological mechanism. The first is warm autoantibody type, because autoantibody maximum react at room temperature, and 50% cases are idiopathic and 50% are secondary to lymphoproliferative disorder or secondary to infection, or sometimes rheumatic disorder can also present. And certain drug like cephalosporin and NSAID can also cause warm type of autoantibody. Second type is cold autoantibody type, which can also happen with TB. Third is mixed type, where both an autoantibody like cold and warm is present. Sometimes some drug like ATT drugs can also present with hemolytic anemia with various mechanisms. AHA mainly present with the symptoms of anemia, weakness, fatigue, dizziness, and dyspnea. Sometimes it can present with the symptom of hemolysis or due to underlying disorder. And less often it can present with hepatosplenomegaly or signs of heart failure due to severe hemolysis. For evaluation, if patient has anemia, we have to look for hemolytic marker like increased direct and indirect bilirubin with increased LDH and reticulocytosis and decreased hepatoglobin. If they are present, we have to proceed for morphological features, spherocytosis, nucleated RBCs, and if agglutinates present, that can happen in cold agglutinin disease or cold agglutinin syndrome. If they are present, then we have to test for DCT. If positive, we have to test monospecific sera. If IgG only present, then this is warm type of AHIA. If IgG plus low agglutinin titer for C3D or IgM present, then this is again warm. If more than 64, then this is mixed type. And if there is C3D positive with increased cold agglutinin titer, then this is cold agglutinin disease or cold agglutinin syndrome based on the underlying etiology present or not. Initially, it was considered that CAD doesn't have underlying cause, but now enough evidence is there that some lymphoproliferative disorder is going on. So till now we have discussed that how to proceed for AHA, and since our patient was a TB induced AHA, so we'll do some RVL on the TB induced AHA. Till now less than 30 cases has been reported to our knowledge, and first case was reported in 1974 by J. Cameron. They reported a 58-year-old male who came with complaint of anemia, jaundice, and productive cough for a history of 3 weeks, and he on evaluation he DCT was positive and hemagglutination happened at 4 degrees centigrade. And chest X-ray showed right upper lobe and right middle zone opacity. So they started patient on folic acid, rifampicin, isoniazid, and prednisolone for 60 mg, and patient showed gradual improvement. And after 8 weeks, they started tapering off the dose, and HR continued for 18 months. They followed up patient up to 2.5 years after the starting treatment, and patient remained improved when he was last examined in August 1972. The second example is from Kuwait, a 24-year-old female who presented with disseminated TB with hemolytic anemia, and they initially started with only ATT, but patient didn't improve, so they started with steroid and patient improved. And they also reported all the they did a literature review from 1974 to 2013 and reported 16 cases and summarized. As we can see, it can present at any age and can involve any site, and main symptom is main lineage is affecting is anemia. Then patient can also present with thrombocytopenia or pancytopenia. It can be any type of AHA, but warm is most common. Cold and mixed can also be present. The treatment was given, ATT was started in all the patients, but cold and mixed type of AHA required glucocorticoid therapy. Third, systematic review was presented, reported in 2018. Their aim was to review systematic review of all reported cases of TB-induced AHA to synthesize knowledge related to this rare presentation, and they included all the cases reported in English literature till 31st January 2017. They also included all the 16 cases that had been already reported in the previous case report. Yes, sir. So they included 21 patients for quantitative synthesis. The fever was the most common symptom, followed by chronic cough, and similarly, pallor and lymphadenopathy was most common symptom, and splenomegaly was present in 19% patients only, and polychromasis spherocytosis the most common symptom. Lab investigations showed hemolytic picture, and in results, lung was the most common site, followed by disseminated TB. ATT was given to all the patients, and 50% patient received blood transfusion. Steroid received by 38% patient, and 29 received all the combination. For TB-induced warm HA, we have to treat underlying etiology. So we treated the patient with the ATT, and folic acid supplementation should be given to match the increased turnover, and standard therapy of AHA should be given, and that depend on the presentation. If patient present with severe or acute presentation, which is explained by, which can be said that hemoglobin is less than 6 or hemodynamic instability. In that case, we have to start patient with methylpred pulse therapy 2050 to 1 gram per day for 1 to 3 days. Transfusion if required, IVIG if underlying infection is present. Early rituximab in a high dose can be considered if there is no response, and anticoagulant therapy can be given. Should be given if there is no contraindication. If patient is present with non-acute or non-severe disease, then standard dose of 1 to 1.5 kg for 3 to 4 weeks, followed by slow tapering should be started. And if there is no improvement in hemoglobin or active hemolysis sign is present, then we have to hold the tapering and proceed for we have to proceed for a second line therapy, that is rituximab. Even after the patient doesn't respond to 8 to 12 months of treatment, then we have to re-evaluate the patient. And if patient's age is less than 65, we have to proceed for splenectomy. If age is more than 65, we can consider a patient enrolling in the clinical trials or steroid sparing agents. To summarize, basically we have to maintain a high level suspicion because of there is high prevalence of TB in India, and the prognosis and recovery is very promising, that we have seen in the case reports and systematic review. Only one case, one mortality has been reported till now from India, Nagpur, and we have to prioritize comprehensive treatment of the underlying disease with addition of short-term immunosuppressive therapy. Otherwise, patient can relapse, as happened in our case also. Now, I would like to invite Dr. Pramod sir to conclude. Thank you, Dr. Sunil. Very well presented. So, in the end, we'll say that it was a very common diagnosis. Tuberculosis quite commonly seen in our practice, almost for all departments too. And also, in older adults, anemia and pancytopenia is also common. In TB patient, around 70%, 60 to 70% have anemia, but autoimmune hemolytic anemia is quite rare cause of TB-induced anemia. And so we try to present this case in our CCR. It also has this treatment benefit, as a steroid has a good prognosis in these patients. As we saw, our patient has responded to the steroid treatment. Counts have improved. Clinically, she is better. And on PET scan also, there was a decrease in the uptake, in the lymph node size and uptake. So with that message only, we'll like to conclude. Any question or any, we'll also like to thank the other department who helped to evaluate and in management of this patient: pulmonary medicine, radio diagnosis, nuclear medicine, hematology and infectious disease. So with that, we will conclude. And any question or query? Yes.
I just want to confirm that there is no way you can differentiate tuberculosis from the only question I do perhaps. How it helps you or the side way to get things to do. Second thing, the cause of this hypersplenism, the nuclear medicine is to demonstrate actually spleen to the very simple test. You can normally level of see they go to the spleen, they come out. But they are red, they will so once we say the ratio of the spleen, the spleen of the will. So it's all we put that in the hyperspleen to put a man spleen is the part of the structure. You can make the point that to always be different diagnosis, history, tuberculosis, can never see it in Quran. Work our fingers never.
Thank you, sir. So our patient was found positive for tuberculosis in the bronchoalveolar lavage. So that confirmed one diagnosis. We also wanted to see the response, so we did the PET scan. Thank you.
So I welcome everybody to CCR by Department of Orthopedics and Trauma Center, and we're going to present a very interesting and rare case of a distal femur fracture, and all the bones were involved in that patient, very rare diagnosis and a pathological fracture. I would invite Dr. Vivek Trikha to Dr. Nishank to present the case. Good afternoon, everyone. I am Dr. Apurva, and on behalf of the orthopedics team at JPNATC, I would like to be presenting the case, which is a mending a broken flask. So, to begin with a brief history, ours was a 22-year-old male patient who presented following a fall, which he sustained as he was pushed during a scuffle, and he presented with swelling and pain over his left lower thigh. The patient also had a deformity and angulation which can be noted, and he had an inability to move his knee, and he was unable to bear weight on the left lower limb. So following our routine guidelines as per our ATLS guidelines, a primary survey was done, and his left lower limb was immobilized in a Thomas splint. In the further local examination, the patient had a fusiform bony swelling over the left lower thigh, and there were abnormal movements, which is known as, and along with crepitus, proximal to the swelling in the left thigh. A similar swelling was also noted in the right side, but there was no crepitus or any abnormal mobility which was noted in the right side. So following a routine protocol, we moved on to begin with our X-rays for these patients. And I would like to call our SR from radiology for this.
Good afternoon, everyone. I will be discussing the radiological part of this case. So this is the first X-ray which was taken on the day of trauma. The bilateral thigh and bilateral knee. There is a pathological fracture noted in the distal end of the left femur through the lesion noted in the metaphysis of left femur. The lesion is intramedullary lytic lesion, which geographic pattern, and the lesion shows here the endosteal scalloping. And there are few areas of chondrite matrix mineralization noted within the lesion, and no soft tissue component seen, no evidence of periosteal reaction seen. Same as symmetrical lesion also noted in the right side of the femur, and similar lesion symmetrically noted in the bilateral greater trochanter of femur. And the knee joint proximal tibia also show the similar lesion involving the symmetrically in the bilateral proximal aspect of tibia in the metaphyseal region. And distal tibia, fibula, and ankle joint shows no evidence of no focal lesion. And NCCT was done on the same day. You can see the fracture involving the left distal one-third of femur. There is hypodense intramedullary lesion which is causing expansion of the femur, and we can able to appreciate very clearly in this chondrite matrix mineralization within the lesion. And there is no periosteal reaction, no extracellular involvement of the lesion, and no soft tissue component within the lesion. And this is the coronal reformatted images showing the similar finding. and also the findings also noted in the bilateral greater appeal. In bilateral shoulder joint also show the same lesion, geographical lighting intramedullary lesion causing expansion and few areas of industrial scalloping in the symmetrical patient. Although the contact matrix mineralization not clearly appreciated in this patient, and the frontal chest radiograph shows the bilateral medial end of clavicle enlarged, fusiform enlargement of bilateral medial end of clavicle noted, and with the expansion within the medullary cavity. And similar lesion also noted in the distal end of radius and bilaterally and right side of ulna. And here also we can able to appreciate the contact matrix mineralization bilaterally. And skull X-ray shows no lesion, and screening of spine shows no focal lesion noted. So multifocal expansion lytic lesion, predominantly metafacial aspect with a narrow zone of transition and areas of contact calcification. No periosteal reaction, no soft tissue component noted within the lesion. So findings are consistent with multiple enchondroma, consistent with multiple enchondromatosis, and there are few subtypes of enchondromatosis described. Here, this patient, the lesions symmetrically involved metafacial regions of proximal humerus, femur, proximal tibia, distal end of radius, ulna, and medial end of bilateral clavicles. These features are classically seen in genochondromatosis type 1. It's a rare type of enchondromatosis. So I would like to discuss the spectrum of enchondromatosis. The most common multiple enchondromatosis is Olier's disease, but Olier's disease will have a unilateral involvement, multiple enchondromas, and usually asymmetrical pattern. And the type 2 genoenchondromatosis will have involved bones of hands and feet, and usually the type 2 it won't involve the medial end of clavicle, whereas in type 1 genoenchondromatosis the medial end of clavicle will be involved. And spondyloenchondrodysplasia is another multiple enchondromatosis spectrum. Here, along with multiple enchondroma, there will be vertebral abnormalities like flat vertebra and platyspondyle. And metochondromatosis, in this case type, there will be multiple enchondroma that associated with osteochondromas will be associated in this case. And Maffucci syndrome, the multiple enchondromas associated with hemangiomas noted, and in plain radiograph we will be able to see the soft tissue calcification or soft tissue plebolith, usually seen in case of multiple hemangiomas. And enchondromatosis type 2 glutaric aciduria, in this type there will be multiple enchondroma involving the metaphysis of long bones symmetrically, as well as the flat bones, and associated spinal involvement also seen.
As there were many differentials which were possible and a large radiological spectrum, we would like to call I would like to call my colleague from pediatric genetics to further elaborate.
Good afternoon. I'll be continuing on genetic part of this case. So, enchondromatosis belongs to group 30 of nosology group of international for skeletal dysplasias. As a broad group, enchondromatosis involves many different division diagnoses. So, the broad group division will be the involvement of either the spinal involvement is there or non-spinal involvement. Within non-spinal involvement, that is two other categories. One is non-hereditary cause, where the non-hereditary is that majority of the cause, like common disease like Olier and Maffucci, that is somatic mutation which is causing the disease. And whereas the other case in autosomal dominant metochondromatosis, there will be and genochondromatosis, which our case also belongs to, they are involved particular gene involvement is there. Whereas Olier and Maffucci syndrome is caused by somatic mutation in ITH1 or 2 gene, but metochondromatosis is caused by autosomal dominant involving TTP11 gene. Whereas genoenchondromatosis, whether it's type 1 or type 2, differentiation is whether involvement of clavicle or not. the gene has not been identified still. And the other group is the enchondromatosis, where there is significant spinal involvement. Here the division again has come with whether the genetic possibility has already been established, like in autosomal recessive spondylochondrodysplasia, where ACP5 mutation has already been established, which in turn is classified into type 2 and type 2 depending upon whether the classification is present in the vertebra. Whereas the other two groups like chirospondyloenchondromatosis and dyspondyloenchondromatosis are not defined accurately. Whereas the dyspondyloenchondromatosis, recent cases have been established that COL2A1 mutations are being associated with these cases. So genoenchondromatosis, the geno in itself is represent knee because when the first case was being described for the genoenchondromatosis, the symmetrical lesions were noted in the lower end of the femur and upper end of the tibia, and subsequent cases also has been reported with the same symmetrical involvement. Hence, such a name was been given. And as I said, the calcific lesion is involved in the metaphyseal of this region, and it has been described as benign in nature. It may regress by adulthood, but no malignancy has been reported till now. This is the characteristic lesion, and the second picture is showing the involvement of the medial end of the clavicle, suggesting type 1 genoenchondromatosis. And as the most common presentation for enchondromatosis is Olliers disease, how we could able to clinically differentiate between genoenchondromatosis and Olliers diseases, presence of symmetrical lesion in genoenchondromatosis, and there will be no involvement of spine. The general growth will not be affected, and there will be characteristic family history. If you see the literature review, although the first case has been reported by Rosberg et al. At 1959 with 3 affected family members, and they described type 1, and in 1992 by Kostowski, who described the type 2 case with 2 affected family members. Till now, we have reached to 2023. Still, we couldn't able to identify the genetic mutation in this case. Our index family also has 6 affected family members, and out of them, 5 affected. 1 is mother and 4 male children. So, although the established gene has not been found out, there are papers coming up. Still, investigation is going on. This paper was published in 2017 from China. A group was working where they used microarray technique to find out from the tissue sample as compared to the control whether there is any differentially expressed gene, whether there is some gene is underexpressed or overexpressed compared to the normal control sample, and they could able to find out these through the cake pathway network. They could able to find out these all possible genes which could be a possible cause for genetic underlying in genoenchondromatosis, and also in enchondromatosis per se, depending upon the underexpression or overexpression compared to the control samples. But still, the investigation is undergoing to establish the exact genetics. Thank you.
So moving on to how we manage this case. So there are certain important differences between how a normal bone that is fractured is managed and how a pathological bone that is fractured is managed. Most importantly, before jumping onto the fracture fixation, we would want to know something more about the nature of the pathology that has afflicted the bone. Almost certainly we would want to know whether the pathology is benign or malignant, because it has vast repercussions on the way a fracture is fixed and managed. If possible, we would also want to have a confirmatory diagnosis, as long as it does not unduly delay the management of the fracture. So in this case, as we saw, with the help of our radiology and genetic clinic colleagues, we knew what we were dealing with. So even if it was a normal bone which is fractured at this site, which is very close to the knee joint, there are a lot of dilemma as far as treatment options are concerned. The fact that this was an abnormal bone that was fractured only compounded this dilemma further. So the normal treatment options for a fracture at this site are first non-operative management, which is basically wrapping the patient's leg in a circumferential cast for around 6 to 8 weeks, after which gradual mobilization of the knee joint and weight bearing can be done. The second option is doing the plating, which a plate is applied on the surface of the bone and is fixed to the underlying bone with screws. The third option is an intramedullary nail, which passes inside the bone, inside the medullary canal of the long bone. And this is fixed to, this is locked with screws which pass through the nail. So broadly, these are the 3 main treatment options which are possible for a fracture at this site. Of course, a nail can be passed from the upper end of the femur, which is known as antegrade nailing, or from the lower end of the femur through the knee joint, which is known as retrograde nailing. So around half a century back, most of these fractures were managed with cast, but in modern orthopedic practice, the role of management of such fractures with a cast is limited to patients who are too sick to be operated. The reason is that there are certain complications which are cast which we would want to avoid. First of all, it puts out an active patient out of action for almost 3 months. It can also lead to delayed mobilization of the joint, which can lead to a lasting stiffness of the joint. And there are complications if this is not correctly done. Complications like plaster sores or neurovascular compromise. So not a very good option to exercise for this particular fracture. Now, plating is normally performed many a times for a normal bone which is fractured at this site. But in our case, the bulbous enlargement of the distal end of the femur that you see associated with this lesion actually causes a mismatch in the curvature of the plate. The commercially available plates are contoured according to the normal anatomy of the bone. So this bulbous enlargement actually leads to a mismatch in the curvature of the plate and the anatomy of the distal femur. So a plate which is normally put on the surface of the bone will not fit correctly on this enlarged sort of a bone. Also, of course, fixation with a plate is an open surgery, and there is an increased risk of bleeding. It increases the surgical time and eventually increases the risk of surgical site infection. So here you can see the pre-contoured plates which are commercially available, which normally match the contour of a normal bone. The non-pre-contoured plates, which have to be manually bent, do not usually provide a stable enough fixation to allow mobilization of the knee joint. The next surgical option which was possible is an intramedullary nail. Now, since the fracture was very close to the knee joint or the lower end of the femur, antegrade nailing inserted from the upper end of the femur is not a very biomechanically sound option. Nailing through the knee joint was a challenge in this case because of the distorted anatomy of the lower end of the femur, from where the nail is supposed to enter the bone. So another challenge that we found in our case was actually achieving and maintaining a stable reduction. Now, with an intramedullary nail, as long as the two ends of the fracture are cylindrical in shape, the nail which passes into the medullary canal, which is the hollow of the bone, actually the passage of the nail itself leads to reduction, and a snug fit of the nail helps in achieving a stable reduction. But in our case, this flask-like deformity of the lower end of the femur that we saw had changed one end of the fracture to a conical flask sort of a shape rather than a cylinder. So in this case, the passage of the nail inside the hollow of the bone will not align the fracture, nor will it lead to a stable fixation. So now I invite Dr. Samarth, who will speak about the intraoperative steps and share with us the results of our treatment for this patient.
Thank you, Dr. Nishank, for explaining it so beautifully. And I'm thankful to our colleagues in genetic clinic, Dr. Madhulika Kapra and Dr. Nirja, who are here, who helped us narrow it down to a diagnosis, and the radiology colleagues led by Dr. Shiva and Dr. Atin, and also Dr. Manisha Jana, who has special interest in skeletal dysplasias when it comes to radiology. So thanks to both these teams and our anesthetic team, which helped us to operate upon this patient. So when it comes to nailing and distal femur fractures, it is not a very difficult job. Most of these fractures, what we do is we go through the knee joint and we may try to make an entry. When we try to make this entry, we just look at an AP view in the anterior posterior view radiograph of the knee, and we try to go into the center and into the center of the canal. And when we look at a lateral view here, we just look at this line here. This is called the Blumenstadt line, but most of you are not orthopedic surgeons here. So we just look at this line here, go on to this junction, which is the center of the canal, and try to go center in both the views. This is how we start, and then we follow it up with a reamer on the same path, and then we ream and put a nail on this path, and it is as simple as that. But then Dr. Nishank has already explained you the challenges that were related to this case. Yes, the prerequisites that are required for any distal femur nail is the patient should be lying down on a radiolucent table in a supine position with 30 degree of knee flexion, and this patient had knee flexion. Sometimes we don't have knee flexion in these patients when the knee cannot flex, and then it becomes a real challenge to operate upon these patients. But yes, this patient had knee flexion, and we need to put either a bolster, or since we do a lot of operate upon a lot of these patients with a distal femur nail, we have these special radiolucent triangles available in our theater, which makes our job easy. Now in this patient, getting a right entry point was difficult because there is no anatomical landmark that was present because of the distorted anatomy. And yes, in the lateral view, if you see, normally an entry point would have been here, but we had to slightly tilt the lateral point, entry point slightly posterior so that we can put the nail in the center. If you see, all this ballooning of the femur in the lateral view is more anteriorly than posteriorly. So with no prior experience of treating such a patient in the past, I don't think anyone has, because to the best of our knowledge, not even a single patient with this disease has been reported in literature with a fracture of any extremity. So we were probably the first ones to do this, and we made this entry point thinking of normal biomechanics. One thing that I would like to add upon Dr. Nishank is, between a nail and a plate, even if we did have a plate which was anatomically contoured to this patient, between a nail and a plate, a nail is a more biomechanically stable device. And in these very osteoporotic or weak bones, or when they are pathological, there are chances of more fractures happening. And if the plate ends at a certain level, then the chances of fracture happening at that level are more. So anyways, a nail is a better implant for these patients because the nail goes through the entire length of the bone, as well as it gives greater biomechanical stability, which is difficult to achieve in these pathological bones. So we went in with our planning, and the team was led by under the guidance of Dr. Kamran, and the team was led by Trikha sir. And we, after making the right entry, we tried to use this minimally invasive tool. This is called as a finger reduction tool. It is nothing but an angle device, and we can angle it to get the wire in without actually opening up the fracture, and try to preserve the biology of the fracture, which helps us in getting early union in these patients. So once we did that, we tried to put the nail in, but because of this, you see the reduction is perfectly all right when we are reaming and putting the guide wire in. But the moment we put the nail in, because of the weakness in bone and the abnormal morphology, the bone slightly, there is slight misalignment of the nail, as a result of which we use something called as the polar pin or the polar screw. Polar is nothing but these metallic triangles used on the roads to direct the traffic in one direction or the other. It is actually a German word from which it is derived, and we used one of these polar blocking pins, and you see how we have corrected this malalignment from this position to this position. And then those are the intraoperative AP and lateral views showing a good reduction in both these radiographs. And mind you, this is without opening the fracture site at all. This is all biological and minimally invasive, and this is the intraoperative fixation that we got. And that's the the size of incision required to do this is really small, because this is a minimally invasive surgery. You can see the abnormal morphology of the bone, and those are the immediate post-operative x-rays. Yes, there was a problem because the longest screw available is 110. A normal femoral condyle is usually 80 to 90, and this patient had a condyle more than 160. We specially ordered some screws, but they could only make it to 110 because of the biomechanical testing, and that is the longest that we have used in the center of these in the bone. And this is the 6 weeks follow-up of the patient, showing some callus formation, but at 3 months we saw a complete union in this patient. So we were also convinced that there is no delayed bone healing in these patients, because there is no literature to support us whether they heal in that position or not. And coming to functional outcome, this patient has, you can see, full extension of the knee and full flexion of the knee, because we were able to get a good stable reduction and fixation with the nail, and we were able to mobilize this patient and mobilize the knee as early as possible. Something that Dr. Nishank has already talked about. If we don't do that and put them in a plaster, then these patients tend to end up with a very stiff knee, which is almost impossible to treat. So, to take home, a metaphyseal fracture, nailing is difficult. Like Dr. Nishank has explained you, with cylinders and cones, when you put, there are two cylindrical parts of the bone and you put a cylinder within it, everything reduces. But when you have a cylinder and a cone and you make a wrong entry in the cone, then it will not reduce with the cylinder. So if you have valgus flexion or extension, we are putting it, it will stay the way it is in such cases. This patient had a normal morphology of the bone, so there is no tailor-made implant for this patient, and there is no literature to support what to do in these patients. So these are out-of-the-box patients which need out-of-the-box thinking, and sometimes out-of-the-box thinking can be something as simple as a distal femur nail, which is done so frequently for some other fractures. We don't need to always think very differently for something out of the box. And this was a pathological fracture. There was a risk of refracture. Like I've already said, the aim of putting a nail was not just to get it more biomechanically stable. Yes, the plate was not possible, hence the nail was a simpler option. But the most important role of a nail here is not to get a future fracture in any of the other parts of the bone, because if a nail ends at one level, that level will be strong, but the level next to it will be weaker, and the next future fracture will be at that level. And tissue trauma in open fixation happens, and if we disturb the biology, then there can be chances of devascularizing the biology and causing delayed union. So we used simple adjuncts like using a finger reduction tool, using a polar screw, and we augmented our adjuncts for reduction like a reduction triangle to get this metaphyseal reduction right. We used a nail over a plate because the morphology was abnormal and there was no custom made plate available to date for such patients. We used an implant which was spanning the whole femur so that there is no future fracture, or to decrease the risk of a future fracture, and yes, to decrease damaging the biology which is already damaged by the trauma that happens. We used a minimally invasive approach. You've seen the size of the incisions that we've used to approach this, and we've not opened the fracture at all, and we got good results in the end. This is the team. So Dr. Kamran sir, under his guidance and under the able leadership of Dr. Vivek Trikha, we've operated, and this is our team of orthopedics at Trauma Center AIIMS who was involved in the care of this patient. And now we thank you all, and we'll be happy to take any questions. Professor Vivek Trikha, any questions that you have at all? Thank you, ma'am. So we made this patient walk the very next day after the surgery, but with a walker, because we would not allow him to put full weight on a very osteoporotic or a abnormal bone morphology. But at 6 weeks, we let him do partial weight bearing, and at 3 months, he's doing almost everything that he was doing before the injury. And this is almost the same protocol that we would have followed for any other patient as well.
It was told that it's a self-limiting mechanism. By what age?
Dr. Neerja, I think, will be the right person.
So it's a self-limiting disease, not in terms of maybe the not chemochromatosis as such. And your values get more patients because they are prone for fractures and because of the osteoarthritis. So the last time lives nearby many of these, so they have said they often visit us. They had fractures, but they were operated in Calabrese. I don't know what was the technique it was. So no, it is not.
No, it's you don't have to and he is at risk of. For us is to go the opposite side. Yes. He has a similar Flask situation on his opposite side. So it is any word of but there are multiple mixes, so whenever very selective. So any word of phyletic and maybe.
So nobody knows.
Avoiding stuff. Yeah, that's the Let me explain to him that he is more prone to have injuries and fractures. So he better take care of that. But otherwise, I think muscular and because the same thing happens in osteoporotic patients as well. There is a normal. There is a for a case like this, whether it should be going before it is warranted, or should we wait for the thing to happen? That's it.
Density is not that high as we see in osteogenesis imperfecta. So, because even if listed at a very later age, 22 years when that's first fracture, it's usually late onset. It doesn't appear at 2 years or 3 years. So here the youngest patient is 8 years or 9 years. And all of them are adults. Majority of them are adults. So I think the fractures happen at a later age rather than at an early age. And I think the muscular part is because of the enlargement of the joints. They look more muscular. So they
I think as on date, we are still on an expert opinion level. So I think whatever ma'am is saying is because of the expert that she did, but I don't know there's enough literature to support.
we are not able to find out the genetic. It has to be genetic because it is autosomal dominant. Not autosomal, but many of them.
That's one point. Of course, explained intramedullary male is a better option than the not getting persuaded. Like this, or something future. For this particular patient, no, that thought is good. It's innovative also. But what we need to think besides the contouring of the plate is also the management. And many times, just because the plate was not. No, what we did after a lot of discussions was that we should be using the most stable biomechanical implant, which is available for us, which has restored all our whatever we have done, mistakes and all that. It has been very forgiving. It has been proven worldwide that the lower limb fracture, kneeling is the most stable. So we went in for a kneeling for the antegrade or retrograde, it was lower to the knee. So we said that we want fixation to the knee, so we went from retrograde to the knee side. Yes, we can have more long screws for this, or a nail which has got some more bigger or thicker diameter in the initials, 10 centimeters, and then the normal. These are such a rare thing that you do not make customized for that. 80/20 in a nail can definitely be thought of. This will be coming in the next future. But the nails will be there, which will remove all the particular inside that orthopedic bones which are there or the matrices there, will remove it and then put it on. But I think you could do it because of your vast experience of managing non-metabolic fractures. General audience. So, what's the medical legal angle for this? Does this, this fracture will not happen, but a fracture is considered serious injury. So, I wonder how that is approached in situation. The sense is that you should not be entering into any fight with any reason of any person. You do not know what may be happening.